Hi, it's Jambi Kwekai back again. I hope you've clicked the link on my bio to subscribe to my YouTube channel. In 2018, I was fortunate enough to have traveled to the US for specialized treatment because I was dealing with endometriosis and I had stage 4 endometriosis and it had spread all the way to my lungs. At the time, by the time I was leaving Nairobi, I had gone through 18 surgeries. I went through 3 more in Atlanta, Georgia, and I was fortunate to have been treated by one of the best specialists when it comes to endometriosis, Dr. Ken Sinervo, who is the medical director at the Center for Endometriosis Care in Atlanta, Georgia. I had the opportunity to have a sit down with some of the doctors who were treating me in Atlanta, Georgia. Dr. Ken Sinervo, medical director of the Center for Endometriosis Care, is our first guest on our first episode for the Endo series, where we discuss more about endometriosis treatment options, management options, and why it is so hard for patients across the world to access the treatment, the gold standard of treatment for endometriosis, which is excision surgery. Take a listen.
My name is Dr. Ken Sinervo. I've been dealing with endometriosis pretty well since I started my career. I came out and I did a fellowship in advanced laparoscopic surgery. And then after that, I joined the Center for Endometriosis Care. So, I really kind of jumped right into it. I started out as an associate with the practice, and then I became the director. And so currently I'm the medical director of the Center for Endometriosis Care. I've been in that position for about 7 years. And we're looking to continue to expand and bring in other doctors who can continue to, address more patients and be able to have this appropriate skill set to do that.
Now, what is endometriosis? Most times we're always asking ourselves, endometriosis ni nini? Mara moja unapata mademu wanapitia mashiro, zina uchungu sana, painful periods, and that come with a myriad of symptoms. What is endometriosis? A disease that's affecting 1 in 10 women. Essentially, all over the world, 200 million women worldwide are battling endometriosis. That means that if all these women came together, they'd form their own country. Can you imagine that? So what is endometriosis?
Okay, well, endometriosis is a tissue that is similar to but different from the lining of the uterus, okay? There's kind of 2 parts to the uterus. There's the lining, which is called the endometrium, and then there's the muscle part, which is the myometrium. When the tissue that's similar to the lining grows outside the uterus, that's called endometriosis, and it can cause pelvic pain, for infertility, and in some other cases it can be extrapelvic as well, such as in your case, in the diaphragm and in the chest, where it can cause either pain, chest collapses, or even fluid to accumulate or nodules in the lung.
Statistics indicate that most women start menstruating at the ages of between 13 to 45. 1 in 10 women experience or have experienced painful periods within the first 6 months of menstruation. In our African cultures, period pain is a taboo topic surrounded by myths. Now, oftentimes, women are told that once they have a child or once they bear a child, period pain will go away. And it's common to hear, ukipata mtoi, hizo uchungu zitaisha. But what exactly are the symptoms of endometriosis? And is childbirth a cure for endometriosis?
Most women, start off having pelvic pain very early on, okay? The great majority of them, anywhere from 60 to 85% of them, start having painful periods within 6 months of starting to have periods, okay? And then gradually their symptoms may progress to the point where they're having either chronic pelvic pain. There are also other sorts of symptoms that go along with that. The bowel is often commonly involved, so patients may have symptoms similar to irritable bowel syndrome. So they may have painful bowel movements, they may have alternating constipation or diarrhea, they may have intestinal cramping. Probably 2/3 of patients are actually diagnosed with IBS. Then they may have symptoms that mimic bladder issues as well. So they may have pain with their bladder when it gets full. They may have urinary tract symptoms mimicking urinary tract infections. Often when the patient is cultured for infection, they don't find an infection, and this goes on kind of for many, many years before they end up getting the diagnosis. Patients will often have painful intercourse. They'll often have back pain, and they may also have problems with fertility as well again.
Birth control is known as a family planning method. But did you also know that it is used to manage endometriosis? It's not to treat endometriosis, but to manage it. Dawa za family planning waga zinatumika sana kumanage endometriosis na kumanage pia mashiru. Wale mademu wako na mashiru za uchungu sana, wengi waga wamepatiwa birth control. Ama siuzitaga ma family planning. Now, how does birth control or hormonal therapy work in endometriosis management?
Birth control is probably the first form of therapy that we use to try to see whether or not it is actually endometriosis or not. And a lot of women will respond to birth control. A lot of patients may have painful periods, but if they respond to birth control, it may suggest that they don't have endometriosis, okay? However, sometimes that can be a bit of a false reassurance as well, because a lot of patients will initially respond to birth control, and then when they either come off it or later on the birth control becomes ineffective in maintaining their pain at a lower level, then it may suggest that they do actually have the disease. So it's a little bit of a false reassurance that they didn't have endo in the first place. The problem with that is often patients will continue to progress, and what might have been a very easy case of endo to treat initially over years of being on birth control, which kind of gave us the false sense of security that there's nothing going on. Their disease may have progressed to a much worse state, and that makes it much more difficult to treat.
Okay, so birth control or hormonal therapy is not a treatment option for endometriosis, but a management option. And the side effects are so grave. A drug like Lupron has been shown to cause osteoporosis in women and long-term effects on bone structure. So what are the options for women battling endometriosis when it comes to hormonal therapy or birth control? And how do you diagnose endometriosis?
Okay, well, the endometriosis is diagnosed first by the patient's symptoms, okay? So if the patient lists the symptoms that we were talking about earlier, painful periods, chronic pelvic pain, bladder, bowel issues, painful intercourse, then it's highly suspicious for endometriosis. If they've been on birth control and failed it, then, you would consider doing a physical exam, okay? And a physical exam, probably for the majority of patients, is going to be normal, okay? But despite that, you still have to just believe the patient that their pain is affecting their quality of life. And the next step really should be a laparoscopy instead of trying to treat them with other forms of medical therapy, because all that does is delays the diagnosis. So one of the things that a lot of doctors do is if the patient fails one form of birth control, either because they have too many side effects or it's just not effective in maintaining their pain, they'll give the patient a different type of birth control. Okay, there's no evidence at all in the literature that one form of birth control is more effective at treating endometriosis pain than another.
The million-dollar question we often ask ourselves, is endometriosis treatable? Yes, it is. But what are the treatment options and how accessible are they?
So instead of trying them on 10 different birth controls, the next step really should be a laparoscopy, because that's the gold standard in how to diagnose the disease. And some patients will undergo a diagnostic laparoscopy just to make the diagnosis before they're given more powerful pain medications or medications to try to suppress the disease. But unfortunately, none of those medications are going to be effective long term. Okay, even the strongest things that we have, like Lupron or other GnRH agonists like Sinervo or goserelin, they will continue to have the endo recur once they've stopped those medications. If you consider treating them long term with those medications, there can be a lot of negative side effects, which could be, life shortening in the long run. So, for example, Lupron, if taken for 10 or 20 years, may affect the bones in such a negative fashion that they may be osteoporotic and die early of a hip fracture or back fracture. So these medications are not without long-term side effects, and that should be really important in terms of considering using them beyond the intended use of them for 6 or 12 months at the most. So that really leaves you with a surgical option. And a lot of doctors will do the diagnostic and then they'll come back and do a surgical treatment. We prefer to make the diagnosis and treat the disease at the same time. So we try to eliminate the need for multiple surgeries because every surgery carries its own risk. Even one surgery, has risks of problems from the anesthesia, and then the risks of the surgery itself. Even putting in a scope carries some risk with it, even without doing anything. So whenever we go in, we plan on treating the disease, okay? And there's different ways to treat the endometriosis. The great majority of gynecologists treat it superficially with a form of treatment called ablation, which includes cautery, laser vaporization, harmonic scalpel ablation. So all of these things aim at trying to destroy the endo. Unfortunately, they have a very high likelihood of recurrence, anywhere from 40 to 60% within the first year, and as high as 80% within a couple of years. So they're much less effective in maintaining a pain-free period for those patients or eliminating the endo. What most endometriosis experts, those who really kind of dedicate their life to treating endometriosis, do is they perform excision. Okay, and with excision, we're almost treating the endo like a cancer. We're cutting out the disease. We're trying to get rid of all of it if we can. And if you're a very good surgeon, you can do that for most patients. The recurrence rate in those situations should be less than 5 or 10% at the most. And while patients may have a recurrence of pain greater than 5 or 10%. There are other reasons for that pain a lot of the time, okay? So patients may have other conditions like adenomyosis, which is basically tissue that's making up the lining of the uterus growing into the muscle layer of the uterus, which can cause a lot of pelvic pain. They may have scar tissue from that surgery. They're less likely to have scar tissue there if they were a lower stage endo patient, like stage 1 or 2. And the risk of scarring goes up with the more severe the disease is. We try to use all different types of different modalities and treatments to prevent that scar tissue from coming back. For example, we use something called platelet-rich plasma, which is something that's been used for many years in treating patients with joint issues, diabetic ulcers, that type of thing, which we know it helps the body heal faster. There was one study which showed that the pain postoperatively was much lower in patients who were given platelet-rich plasma. So, we do it in the hopes that it's helping the patient heal faster and with less pain. And then we also use other products that we know have been effective for many, many years, like Interseed, which is a product that basically is like a soft mesh that we wrap around tissues to try to prevent them from getting stuck together. Then other things like AmnioFix or other amniotic membrane products that stay around a little bit longer. And then we also, in some cases, suspend ovaries if we've done a lot of work around them. And after about a week or so, we can release those ovaries and allow them to, go back to where they normally should be sitting, because most of the healing has already gone on within that, 6 to 7 day period. Okay, so there's a lot of ways of trying to prevent the recurrence of pain, and the incidence of any more endo coming back in someone who's a very good excision doctor should probably be less than 10%.
And remember to subscribe. The link is in the bio.